They recommend clinicians offer to prescribe risk-reducing medications such as tamoxifen, raloxifene, or aromatase inhibitors for women who are at increased risk for breast cancer and at low risk for adverse medication effects.
Yep.
What if we applied this to men? And let's say at age 50, you're a male, you've got some prostate cancer in your family history, and they say, hey, we're going to put you on androgen deprivation therapy, or we'd like to discuss that with you. How does some Lupron sound? Because it is a risk-reducing medication. So then we have some basic guidelines. The USPSTF puts out some guidelines. Some of them really reasonable. Some of them they kind of take a hands-off approach because they want to see the absolute highest level of data supporting something before they put any kind of a recommendation. So a lot of times they're like, we don't recommend this for this, even though it has an effect on this, because the data is not strong enough for their liking. But these are things they feel have a lot of good data to support. So primary care clinicians assessing women with personal or family history of breast cancer, and certain other cancers for BRCA1 and BRCA2. That's a discussion, and then genetic counseling is something that you would refer them for after that.
So that's a very reasonable thing. My mom's been screened for BRCA1, BRCA2. She's had breast cancer a few times. I believe I've touched on this in the past, but also given our family history, that was a reasonable thing to screen for. So it's good to screen for if you have what we call a high pretest probability, a higher than average likelihood of it being positive.
And number 2 here, I'm going to make an analogy after this one. So they recommend clinicians offer to prescribe risk-reducing medications such as tamoxifen, raloxifene, or aromatase inhibitors for women who are at increased risk for breast cancer and at low risk for adverse medication effects. What if we applied this to men? And let's say at age 50, you're a male, you've got some prostate cancer in your family history, and they say, hey, we're going to put you on androgen deprivation therapy, or we'd like to discuss that with you. How does some Lupron sound? Because it is a risk-reducing medication.
Lupron doesn't sound that good, but what about a little bit of enobosarm?
Enobosarm, or
with a little bit
5-alpha reductase
with a little
inhibitor?
bit of Tlando and some dutasteride. That's my stack of choice for an ultra high risk prostate cancer individual. Say I had a Gleason score 5 prostate cancer on biopsy, but I decided not to operate on it.
That would be your medical people who opt for medical management only. That'd be a more reasonable protocol, or at least for preserving quality of life, because you assume that's always a goal of someone and talk about them, what's important to them. And people on androgen deprivation therapy feel like crap. And actually a lot of women on these medications can have adverse effects. So I'm glad that they tagged that last bit on there.
Actually, I'll change my stack. And I know I've gotten flack in the past for just always going back to prostate cancer, which I don't know why we do that, but it's just an easy example to pick. But my stack would be Natesto, not Tlando. So Natesto, I'd feel pretty good. I assume I'd be old enough to where my DHEA wouldn't be high, but if I had some NCCAH, maybe an adrenal steroidogenesis cascade inhibitor, perhaps, enobosarm, and maybe some, depending on what my estrogens were, maybe some estriol, or to trigger people, how about some ecdysteroids, some terkesterone and some beta ecdysterone for the beta estradiol receptor agonism. So that's our theoretical stack.
Then we have mammography. So the USPSTF recommends every other year screening for women age 50 to 74. And this kind of contrasts with the American Cancer Society, who recommends having a discussion about screening at age 40.
So I usually at least have a discussion at age 40, even for someone without any other risk factors. The American Cancer Society says start at 45, and then plus or minus at 40. And then there's kind of like one camp that does every year, some camps that do every other year. I'm more in the camp that does every year.
Yeah, I think I'm on the same side, because we've gotten a lot better at what we do with these things when they're caught early. They're not being over-treated, and cure rates are very high. And obviously, the higher the earlier you catch something, the higher those cure rates are.
Yeah. If there is a lesion that is found, let's say a patient finds a lesion, in general, under the age of 30, they recommend ultrasound for evaluation. Over the age of 30, mammography. If there's a 31-year-old with particularly dense breast tissue, actually, you probably still have to order a mammogram just for insurance.
To cover a biopsy.
Yeah. So ignore that. And then one other thing I thought of is if there's a urologist watching, just so they don't hear her, does not get triggered, we'll say that prostate cancer that I was not going to operate on my theoretical future self, we'll call it a Gleason score like 2 or 3 instead of a 5. It's just to prevent the comments. So we can keep going.
Yeah. So then we have cervical cancer screening, which is pretty common with, well woman visits, getting these depending on your risk factors. And with the reduction of HPV infections, hopefully you'll actually see less of these and also less head and neck cancers.
Yep. Be careful getting these if, like let's say you're on a heavy period, might be more comfortable, but might have slightly higher false positive rates. Be careful getting them right after you have intercourse because it's more likely to show up as ascus, which is basically squamous cells of undetermined significance, like somewhat atypical cells. So that's pretty common to see. So, let's say, and also under the age of 24, there's this is kind of like a fairly recent update within the last 3 to 5 years. It does not always have to go to colposcopy. So it used to be, you're 16, perhaps have a conversation with a physician that you're comfortable with and say you're active, you get a PAP, maybe right after you have intercourse, you have ascus, you have colpo, it's traumatic. Colposcopy is not fun if people have not done it. I obviously have not done it, but as someone who's done it, I know that it's not fun. For the right patient, you should even prescribe them a Valium or a Xanax. But key matter is talk to your physician. Screening recommendations on this have changed a whole lot now that we have high-risk HPV testing. For most people, once you're getting regular negatives, you go every 5 years. And cervical cancer is also one that's heavily affected, obviously by HPV infection, but also by nicotine use.
Yeah, and this probably, contrast what the USPSTF is saying, contrast with ACOG. The ACOG probably has a slightly more up-to-date recommendation because I think they'll retally these things on a more frequent basis.
Yep.
So then we have, this is actually a fairly recent change as well.
Yep.
Colorectal cancer screening. So this is gold standard colonoscopy for people that can't or won't do a colonoscopy. There's the Cologuard. Colonoscopy is still the gold standard though, but getting some screening is better than no screening.
Yep.
And now the age recommendation there is 45. And this is where family history comes into play. If you have someone, let's say your father had colon cancer when he was 50, then your screening actually starts at age 40, 10 years prior to whenever that individual in your family developed colon cancer.
They have, levels of how good colorectal cancer screening is, or CRC screening. I believe one of the societies that the gastroenterologists mainly run, the tier A for whatever reason, is endoscopy, so colonoscopy, and FIT test yearly. Every year, a fecal immunohistochemical test or a FOB. Whereas Cologuard for them is category B, but a Cologuard every 3 years, or certainly, Cologuard is a better test than a FIT test. If you did a Cologuard test every year and a FIT test every year, Cologuard's going to be way better.
But you're going to generate more colonoscopies if you're doing a FIT test every year.
You are. So that's a conversation that you can have with your doctor. But, the other positive of a Cologuard is if you're doing it every 3 years, you're just going to have better adherence because there's not a yearly test that you have to do. The opposite of the FIT test is most microbiome stool tests also have a FIT test in them. So maybe you've already been screened for colorectal cancer and you don't even realize it. If you eat a lot of nitrites, or if you're from some Southeast Asian countries, they also screen for esophageal and gastric cancer with an EGD at the same time.
Yeah, and I think a detail I recall is with these FIT tests, if you have a large bolus of meat, especially if it's a more rare type of steak, then that can generate a positive FIT test. And then you've sort of bought yourself a colonoscopy.
Yep. or hemorrhoids, or lots of
things can give
some
you
ibuprofen,
blood in the stool besides cancer.
Yep. Pentosan, polysulfate orally.
Yeah, they're very high, like 15+% of people on the low end.
Yep. That pretty much covers.
We have lung cancer.
Colon cancer.
And this one is very complicated. Like, this is something that was put together by a statistician, you can tell.
Yep. So, don't turn into a statistic. Talk to your doctor about screening for lung cancer. But they have a low dose CT scan. CT scans do have some radiation, more than an X-ray. MRIs do not have any. But a low dose CT scan certainly has less than a PET scan or a high dose CT scan. But in general, the current recommendation is a 20-pack-year smoking history or more. It used to be 30-pack-year smoking history, I believe. They can't have quit for more than 15 years. So if you quit 16 years ago and you have a 50-pack-year smoking history and you're 70, then I guess you don't get screened. So like anything else, you can always kind of like make an exception. But at least from an overarching view, 50 to 80 history of relatively heavy smoking makes a lot of sense to screen for lung cancer.
Yeah, absolutely. That's something that you do want to catch early when there's perhaps a surgery that could be performed.
Yep. And along with a lot of these, whether it's breast cancer, whether it's lung cancer, it also mentions, that they have a relatively long life expectancy. So if there's someone who is, unfortunately, like in the end of life care stage from another condition, then you don't put them through the anguish of screening them for a cancer that's not going to affect anything regardless of the result.
Yeah. So you kind of, as a clinician, ask yourself, how healthy is this person in front of me? And they set an arbitrary cutoff, sometimes age 75, sometimes age 85.
Yep.
But what if someone lives to be 110? It's more common now. And you see these headlines and people that are 100 plus, they say, oh, I did this and this is why I made it to 100 plus. Mm-hmm. You kind of have to forecast what this person's health trajectory looks like. So if you've got someone with a end-stage renal disease on dialysis that's diabetic, that just had a BKA, that person is probably not going to make it another 10 years. But if you have someone who's 85, still goes to the gym every day, they're very, they have a lot of vitality to them.
They listen to the Gillett Health podcast.
Yeah, you check all those boxes, then that person has a bright future ahead of them.
Next is skin cancer or counseling regarding UV. We mentioned tanning beds. Really not a great reason to use a tanning bed. There's lots of ways to get the skin to appear slightly more tan that are more safe. But yeah, counseling, especially young children, bad sunburns, especially early in life, have a high risk of melanoma. It's like a very severe sunburns. Cumulative sun exposure is more of a risk for basal cell and squamous cell. Of course, there's exceptions and there's genetic predisposition, but this is a reasonable thing to do. No, you don't need to be a vampire, daywalker, etc. your entire life. It's okay to get a little bit of sun. There's benefits of it as well, but you certainly want to limit it.
Yeah, or use appropriate protection, right? You can still get your morning sunlight. You don't have to get a morning sunburn.
Mm-hmm.